Okay, so we're going to pick up where we left off with Chapter 14, the nervous system, with congenital and neurologic disorders. First, we'll talk about hydrocephalus. So hydrocephalus is when more cerebrospinal fluid is produced than is absorbed. So that excess cerebrospinal fluid accumulates in the skull and it compresses brain tissue and blood vessels. If the cranial sutures haven't closed yet, the infant's head will enlarge beyond the normal size. If the cranial sutures have closed, there will be an increase in intracranial pressure. So we have two types of hydrocephalus. We have non-communicating or obstructive. That's usually the result of a fetal development abnormality. The flow of cerebrospinal fluid through the ventricular system is blocked, leading to increased back pressure of fluid in the ventricles that gradually dilates the ventricles and compresses the blood vessels and brain tissue. Then communicating is when the absorption of cerebrospinal fluid through the subarachnoid villi is impaired, resulting in increased pressure of cerebrospinal fluid in the system. So developmental abnormalities are the most frequent cause. This can be stenosis or atresia, and obstruction from tumors, infections, or scar tissue can happen at any age. The flow of cerebrospinal fluid through the ventricular system is blocked, and again, it usually results from a fetal developmental abnormality, like a stenosis or a neural tube defect. It can be associated with a myelomeningocele or Arnold-Chiari malformation is present in lots of babies. Obstruction leads to this back pressure of fluid in the brain ventricles and enlarges the ventricles and compresses the blood vessels in the brain tissue. In that communicating hydrocephalus, absorption of the cerebrospinal fluid through those subarachnoid villi is impaired. The skull can expand to a certain degree to relieve pressure, but if it's not treated, the brain tissue is going to become permanently damaged, like we talked about with an increase in intracranial pressure. In our older children and adults, that intracranial pressure increases more rapidly than in children, tiny babies, neonates. The amount of brain damage depends on the rate of pressure increase and the time of relief. So this is on, page 365 in your book, and it shows that compressed brain tissue, the enlarged ventricles, etc. The signs and symptoms depend on the age of the baby. Scalp veins can be dilated, pupillary response to light is sluggish, the eyes can show the sunset sign where the white sclera is visible above the pupil. The baby will be lethargic but irritable and difficult to feed. They'll have a high-pitched or shrill cry when they're moved or picked up, and it has to be treated as soon as possible to minimize brain damage. Next, we have spina bifida. Spina bifida is a group of neural tube defects that are congenital anomalies of different severities. It's failure of the posterior spinous process on the vertebrae to fuse, so the meninges and spinal cord can herniate, resulting in neurologic impairment. It's most common in the lumbar area. There's three types, and there's a picture on 367 that shows the three different types. So spina bifida occulta is when the spinous processes don't fuse, but herniation of the spinal cord and meninges does not occur. It's usually not visible, but you'll see something like a dimple or a tuft of hair on the skin over the site. It's diagnosed by x-rays or when there's mild neurologic signs from the tension on the spinal cord during growth spurts. A meningocele is also when the spinous processes don't fuse, but in this, herniation of the meninges occurs through the defect. The meninges and cerebrospinal fluid form a sac on the surface. Transillumination confirms that there's no nerve tissue in the sac. There is usually not neurologic impairment, but rupture of the sac or infection can lead to neurologic damage. A myelomeningocele is the most serious form. Herniation of the spinal cord and nerves along with the meninges and cerebrospinal fluid happens, resulting in a pretty severe neurologic impairment. The location and extent of the herniation determine how much function is lost. And here's that picture I was talking about. You can see the differences between the defects and where the meninges come out and cerebrospinal fluid come out in the sac versus damaged nerves and everything in the sac as well. So there's a multifactorial basis for spina bifida. It's a combination of genetic and environmental factors, radiation, gestational diabetes, deficits in folic acid, and a high family incidence have to do with developing spina bifida. To diagnose, we can do it alpha-fetoprotein or AFP level in the maternal blood, so we can check for damage, before baby is born. We can diagnose prenatally by ultrasound or amniotic fluid analysis as well. Signs and symptoms of a meningocele or myelomeningocele are visible as a protruding sac over the spine. There will be a neurological deficit depending on the level of the defect and on the status of the nerve tissue. Sensory and motor function below the level of herniation is going to be impaired. To treat, we do a surgical repair, and then the person will need ongoing help and occupational and physical therapy after the repair. And then next we have cerebral palsy. So cerebral palsy is a group of disorders involving motor impairment caused by genetic mutations, abnormal fetal formation or functional brain areas, infection or brain damage in the perinatal period. Damage can happen before, during, or shortly after birth. The brain tissue is altered by malformation, mechanical trauma, hypoxia, hemorrhage, hypoglycemia, hyperbilirubinemia, infection, or some other factors resulting in necrosis. There can be single or multiple factors in the development. Hypoxia or ischemia is the major cause of brain damage. It can be caused by placental complications, difficult delivery, vascular occlusion, hemorrhage, aspiration, respiratory impairment in a premature infant, or high bilirubin levels. It can also be caused by infection or metabolic abnormalities like hypoglycemia in either mom or baby. It's classified into different groups, and you can see the types of classifications of cerebral palsy on page 368 in that table. The first group is the largest, and it includes people with spastic paralysis. The area of damage here is the motor cortex or pyramidal tracts, and the effects are paralysis, hyperreflexia, and increased muscle tone. The second group is the dyskinetic disease. This results from damage to the extrapyramidal tract, basal nuclei, or cranial nerves. And here the effect is a loss of motor control and coordination and athetoid or coriform movements. The third group is ataxic cerebral palsy, and this has to do with a damaged cerebellum. The effects will be gait disturbance and loss of balance. That spastic paralysis, like I said, is a result from damage to the pyramidal tracts, motor cortex, and general cortical damage, characterized by hyperreflexia. Dyskinetic is damage to the extrapyramidal tract, basal nuclei, and cranial nerves, and you'll see the athetoid or coriform involuntary movements. And ataxic is damage to the cerebellum, loss of balance and coordination is what you'll see. There's also a mixed, which is a small percentage, and it is like all of the above: damage to the motor cortex or pyramidal tracts, basal nuclei or extrapyramidal tracts, and the cerebellum. And as far as effects, you'll see some of each of the effects that we just talked about: paralysis, hyperreflexia, increased muscle tone, loss of motor control and coordination, athetoid or coriform movements, gait disturbance, and loss of balance. So it really is going to just be a little bit of everything that we talked about. Some other common areas of dysfunction are intellectual function. It varies from normal intelligence to severely cognitively disabled in a small percent of cases. Communication and speech become difficult because of motor disabilities, seizures, visual problems, visual or hearing deficits. So to treat cerebral palsy, we have individualized therapy because everybody is going to have different areas of damage and different effects. We're going to do early stimulation programs, language pathologists, physical therapy, exercise therapy, use supportive devices, and occupational therapy. And then next we'll talk about chronic degenerative disorders. First is multiple sclerosis. So multiple sclerosis is the progressive demyelination of neurons in the brain, spinal cord, and cranial nerves. There's multiple types of multiple sclerosis that vary in severity, effects, and progression. The loss of myelin interferes with the conduction of impulses in the affected fibers. So this can affect motor, sensory, and autonomic fibers. It occurs in diffuse patches throughout the nervous system. The earliest lesions happen as an inflammatory response, as cells that normally don't enter the brain or spinal cord do and attack neurons with loss of myelin in the white matter of the brain or spinal cord. Later, larger areas of inflammation and demyelination called plaques become visible, usually beside the lateral ventricles in the brain stem, and in the optic nerves. The plaques vary in size, and several can group together into a single patch. The initial inflammation might subside and neural function can be returned to normal for a short time until another exacerbation happens. In time, neural degeneration becomes irreversible and function is lost permanently. With each exacerbation, additional areas of the central nervous system are involved. The onset is usually between 20 and 40 years old. The cause is unknown, but it's thought to be an autoimmune disease, hereditary, and more common in females. The signs and symptoms are determined by the areas of demyelination. They can be like blurred vision, weakness in the legs that progresses to paralysis, diplopia, which is double vision, and scotoma, which is spots in the visual field, dysarthria, which is slurred speech, paresthesia, which is numbness and tingling, progressive weakness and paralysis progressing from the legs up, loss of coordination, bladder and bowel dysfunction, sexual dysfunction, and chronic fatigue. This is on page 373 and it shows the distribution of the lesions. So to diagnose, there's not a definitive test, but we will do an MRI to diagnose and to monitor. We'll do continuous MRIs to monitor the progression of the disease. There's no definitive treatment at this time as well. There's lots of different research trials in progress, but we're gonna do therapy like physical therapy, occupational therapy, and then we're gonna focus on the signs and symptoms that require individual attention. And then next we have Parkinson's. So Parkinson's disease is a progressive degenerative disorder that affects motor function through the loss of extrapyramidal activity, which is reflexes, locomotion, complex movements, and postural control. There's progressive degenerative changes in the basal nuclei, creating an imbalance between excitation and inhibition. Excess stimulation affects movement and posture, so you'll see resting tremors, muscular rigidity, difficulty initiating movements, and postural instability. The primary or idiopathic Parkinson's disease usually develops after age 60, and secondary could be caused by encephalitis, a trauma, vascular disease, or it could be drug-induced. Early signs and symptoms are fatigue, muscle weakness, muscle aching, decreased flexibility, and less spontaneous changes in the facial expression, tremors in the hands at rest, and this repetitive like pill rolling motion of the hands. The later signs and symptoms are tremors that affect the hands, feet, face, tongue, and lips, increased muscle rigidity, difficulty initiating movements, slow movements, lack of associated involuntary movements. Characteristic standing posture is stooped and leaning forward. You can see a picture of that on page 374. And this propulsive gait, or this like shuffle, we call it like the Parkinson shuffle, and complex activities become slow and difficult. This is that picture I was talking about. It shows the characteristics of Parkinson's. In Parkinson's, there are some other areas that are affected as well. The person will have a low voice, and it says it's devoid of inflection. That just means a low monotone voice. Dysarthria, chewing and swallowing trouble. It might take them longer to eat. They might drool excessively, and they have this like mask-like facial features. So their eyes don't blink as often, kind of a blank staring face, and this also impairs their communication. Autonomic dysfunction like urinary retention and constipation, similar like we talked about with autonomic dysreflexia, so they may need assistance there. Orthostatic hypotension, urinary tract and respiratory tract infections are common here, and dementia will develop in the later courses of the disease. But in the earlier courses of Parkinson's, they're cognitively aware, they're just unable to coordinate that movement. To treat Parkinson's, we remove the cause if we have a known cause. We can do dopamine replacement therapy. We can do monoamine oxidase B inhibitors, anticholinergic drugs, speech and language pathology, physical therapy, occupational therapy, and then we're going to monitor and treat any respiratory and urinary tract infections. Next, we have amyotrophic lateral sclerosis, or ALS, or Lou Gehrig's disease. It's a muscle wasting and degenerative hardening of the lateral corticospinal tracts. The cause is unidentified, but genes on various chromosomes have been linked to it. It's a progressive degenerative disease that affects both upper motor neurons in the cerebral cortex and lower motor neurons in the brainstem and spinal cord. There's no indication of inflammation around the nerves, and cognition is not impaired with ALS. There's a loss of the upper motor neurons in the cerebral cortex, like I said, so it causes a spastic paralysis and hyperreflexia. The damage to the lower motor neurons causes this flaccid paralysis and decreased muscle tone and reflexes. The progressive muscle weakness and loss of fine motor coordination causes stumbling and falls, and death usually occurs in ALS because of respiratory failure. There's no specific treatment to slow the degeneration. We are investigating stem cell therapy, but that's a hot topic always. There are pharmaceutical or medication treatments to slow further damage to the neurons. We recommend moderate exercise and rest, respiratory therapy, appropriate nutrition, speech therapy, occupational therapy, physical therapy, and then psychological help as well. And then we have myasthenia gravis. This is an autoimmune disorder with autoantibodies to acetylcholine receptors. It causes destruction of the receptor site, preventing further muscle stimulation. So it causes skeletal muscle weakness. Facial and ocular muscles are usually affected first. Dysphagia and aspiration are significant problems with myasthenia gravis. We do an EMG, or electromyography. We talked about electrocardiography, or EKG with cardiac, electroencephalography with like seizures and stuff like that in neuro, but we can also do electromyography to monitor the electrical activity of the muscles. We can also do serum antibody testing for diagnosis. Signs and symptoms are muscle weakness, especially in the face and eyes, impaired vision, monotone speech, difficulty chewing and swallowing, a drooping head, and the arms are going to become weaker, and upper respiratory infections are very common. We treat with anticholinesterase agents to temporarily improve the neuromuscular transmission, glucocorticoids to suppress the immune system, because again, it's an autoimmune disease. We'll use other immunosuppressants as well. We can do plasmapheresis, we can remove antibodies from the blood, and we might even do a thymectomy. And next we have Huntington's disease. It's an inherited disorder that doesn't show up until midlife. It's progressive atrophy of the brain with degeneration of the neurons. Signs and symptoms are mood swings, personality changes, restlessness, and coriform movements, or rapid jerky movements in the arms and face. We detect the gene by doing DNA analysis, and sadly there's no treatment to slow the progression of the disease. Signs and symptoms at the beginning are mood swings and personality changes, and those restlessness and those coriform rapid jerky movements in the arms and face. There might also be early indications of intellectual impairment, like difficulty learning new information, loss of problem-solving skills, poor judgment, inability to concentrate, and memory lapses. As it progresses, you'll see rigidity and akinesia that develop, making any movement difficult, more personality changes, moodiness, and behavioral disturbances as the dementia progresses. To diagnose, we use a DNA analysis, and there's no therapy to slow the progression. We just treat the symptoms of it. And then we have dementia. So dementia is a progressive chronic disease where cortical function is decreased, impairing cognitive skills like language, logical thinking, and judgment, the ability to learn new information, as well as motor coordination. Loss of memory affects primarily short-term memory, but the person can also be confused about events in long-term memory. There are usually behavioral and personality changes. We see a lot of people with dementia becoming paranoid. They know that something is wrong, but they don't know what is wrong. So they get frustrated because they can't figure out what's going on. My husband actually had to stop visiting his grandma because she didn't remember who he was. And she would get scared that this strange man was coming into her room. It's really heartbreaking. It's difficult for family as well as the patient. There are lots of causes of dementia like vascular disease, infections, toxins, and genetic disorders. When we're looking at the possible diagnosis of dementia, first we want to make sure that there are no problems. These can be mistaken for dementia signs and symptoms. Like some of them can lead to dementia, but we don't want to think someone has dementia when really they're just drunk or hard of hearing or something like that. Alzheimer's disease is a progressive loss of intellectual function that eventually interferes with life. There's progressive cortical atrophy that leads to dilated ventricles and widening of the sulci. You can see this on page 376 in the book. The top brain is, or the left brain is an Alzheimer's brain that's smaller with narrow gyri and wider sulci, and the right brain is the normal brain. Oh, sorry, never mind. That's Huntington's. On page 378, you can see the Alzheimer's brain and the normal brain. Neurofibrillary tangles in the neurons and senile plaques are found in large numbers in the affected parts of the brain. The plaques disrupt neural conduction. There's also a deficit in the neurotransmitter acetylcholine. There are no definite diagnostic tests available. We diagnose by excluding other disorders and by obtaining a careful medical and psychological history. The specific cause is unknown. There are repetitive DNA sequences on different chromosomes that have been associated with Alzheimer's, though. Signs and symptoms are an insidious onset that lasts longer than 10 to 20 years, or around 10 to 20 years, sometimes longer. Behavioral changes like irritability, hostility, and mood swings, impaired learning, poor judgment, decline of cognitive function, memory, language, change in food intake, inability to recognize family, lack of environmental awareness, incontinence, inability to function, gradual loss of memory and lack of concentration, anomia, which is the inability to remember the names of things, apraxia, which is misuse of objects because of the failure to identify them, and agnosia, which is inability to recognize familiar objects, tastes, and sounds, and amnesia, which is memory loss, and aphasia, which is the inability to express yourself through speech. There's no specific treatment. We can use anticholinesterase drugs. There are some this might lead to some temporary improvement. We also use occupational therapy, psychologists, speech therapy, but we really use a whole team to support the patient and to support their caregivers as well. And then next we have mental health disorders. So they're classified in the DSM-5. They're dysfunctions in the areas of behavior or personality. They're biochemical and or structural abnormalities that can be identified along with mental health disorders. There's a potential genetic component associated with them as well. Psychotic illnesses include schizophrenia, delusional disorders, mood disorders, anxiety, and panic disorders. So schizophrenia is a variety of syndromes that's present differently, or that present themselves differently in each individual. The common changes include reduced gray matter in the temporal lobes, enlarged third and lateral ventricles, abnormal cells in the hippocampus, excessive dopamine secretion, decreased blood flow to the frontal lobes, and there are theories about genetic predisposition or brain damage in the fetus. I've also heard that marijuana and other drugs can lead to schizophrenia. The symptoms are grouped into either positive symptoms or negative symptoms. So positive symptoms are delusions and bizarre behaviors, and negative symptoms are things like flat emotions and decreased speech. So think of positive as like usually we think of positive in a good way, but positive symptoms are going to be when things are present, like delusions are present, their behavior, a bizarre behavior is present. Negative is when things are not present, like their emotions are not present, their speech decreases or is not present. So kind of think of positive and negative in that way. None of them are good symptoms. General symptoms include disorganized thought processes, impaired communication with inadequate language skills, and delusions or false beliefs and ideas. To treat, we use antipsychotic drugs. These cause lots of different side effects related to excessive extrapyramidal activity, or that muscle spasms of the face, neck, or arms or legs. They'll have like this chewing or lip smacking motion that they do. They may also have repetitive jerky or writhing movements. Some side effects might be reduced by anti-Parkinson medications as well. So sometimes people that don't have Parkinson's are on anti-Parkinson medications to help with the signs and symptoms from Parkinson medications, from schizophrenic medications. We'll also use psychotherapy and psychosocial rehabilitations with our schizophrenic patients. Then we have depression. It's a common problem and it often happens in people with chronic illnesses. It's classified as a mood disorder with several subgroups. There's unipolar, which is endogenous. It's diagnosed based on biological factors or personal characteristics. And then there's bipolar, which is alternating periods of depression and mania. It's a response to a life event or secondary to a systemic disorder. Factors include genetic, developmental, and psychosocial stressors. Depression results from decreased activity by the excitatory neurotransmitters norepinephrine and serotonin. We don't exactly know why it happens. It's suggested or thought to be a genetic component associated with it, but we're not entirely sure. It's indicated by prolonged periods of unfounded sadness with lack of energy, loss of self-esteem and motivation, irritability and agitation, insomnia or excessive sleep, and loss of appetite and libido. To treat, we recommend counseling combined with antidepressant drugs that increase the norepinephrine activity, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, tricyclic acid antidepressants, monoamine oxidase inhibitors. It just depends on what works best for that patient. We can also do electroconvulsive therapy for severe cases of depression, and I kind of thought that we weren't doing electric shock therapy anymore. But when I was in clinicals, I actually had patients that went down for electric shock therapy. It's pretty interesting. Next, we have panic disorders. A panic attack is a sudden brief episode of discomfort and anxiety. Panic disorder happens when panic attacks are frequent and prolonged. There is a genetic factor thought to be associated with panic disorders. There's an increased discharge of neurons in the temporal lobes and neurotransmitter abnormalities in the norepinephrine, serotonin, and GABA receptors. Signs and symptoms are episodes of intense fear without being provoked. They can last for minutes, they can last for hours, and physical signs and symptoms happen as well because of this intense fear. So palpitations or tachycardia, hyperventilation, sweating, sensations of being choked or smothering, potentially nausea. So to treat, we do psychotherapy, and we might use meds as well, like anti-anxiety and antidepressant meds.